Anyways, perhaps we should get started here. I just want to say hello to everyone and welcome everyone on behalf of Critical Care Services Ontario. This is our inaugural webinar, part of our series that we've called Ontario Critical Care Clinical Practice Rounds, which we are affectionately calling OC3PR. And yes, that sounds like a character from Mike Sullivan's favorite movie, but rather it's our attempt to help people like you, the real health professionals caring for critically ill patients, this truly the sickest of the sick. Now, I trust all will appreciate that we're not technological experts here and we're still learning, so there may be a few glitches today. Just to give you an example in the background, we found out that Bernard Lawless's computer was still using Windows 98. So you can imagine what the CCSO team has had to overcome in a short period of time, learning about YouTube channels and various other things.
Thank you very much, Dave.
Here's Dr. Lawless. This series has been created to help address a need that was expressed to CCSO by various groups. It's there to help all health professionals with its purpose of being to promote learning.
Visiting hours are now over. Visiting hours are now over.
So we're going to mute everyone when we can here. It's better to help align Ontario's critical care teams in the care they provide, both in terms of medical and management issues, but also in terms of staffing and how they organize their intensive care units. Our focus will obviously initially be on COVID-19 issues, but we're also intending to look at other challenges as well. Today and in the future, we'll hear from experts and various professionals. There's an opportunity for to send in your questions both before a talk, but also during it. Today, it was to be Dr. Neill Adhikari collating the questions, which we encourage you to send in by the Zoom chat function to Q&A, which will be in front of his name or in front of José's name if Dr. Adhikari is not able to join us. We'll be working for a better way to do this in the future, but bear with us. We've overcome a lot of barriers to get to where we are now, and certainly the CCSO teams to be commended for this. We encourage you to send in your ideas, suggestions, and tips to the email address info@ccso.ca. We'll also take the questions that aren't answered today and bring them in the third webinar that will be on COVID-19 in December of this year. We also encourage you to follow CCSO on YouTube and on Twitter as well to get more frequent updates and linkage. When I think about this year, certainly back in the spring when the initial reports of COVID-19 began to surface, there was certainly an emphasis, I recall, on intubate patients early. This was obviously based on anecdotal reports, which in hindsight may have influenced outcomes of wave one and unintended consequences. I think many of us will recall the challenges of wave one, some of the negative repercussions that some experienced while trying to advocate for high flow oxygen devices, along with various other means of helping COVID-19 patients. So it's going to be interesting today to hear about the management of COVID-19 patients today with the many changes and recommendations that have come out in the last weeks to months. Our focus today will be on the management of COVID-19 patients before they are intubated. And we'll be hearing of this from our speaker today, who is Dr. Stephen Lipinski. Dr. Lipinski is a professor of medicine at the University of Toronto and is the current director at Mount Sinai ICU in Toronto. He's trained as a pulmonologist and a critical care doctor in Johannesburg and has been based in Toronto since 1992. He certainly has had a distinguished clinical and academic career with an emphasis in various fields, including pulmonary illness, continuous dialysis, as well as mechanical ventilation. His objectives today are ambitious, but are there to help us better understand and appreciate hypoxic oxygen saturation, better appreciate the complex issue of airborne viral transmission, as well as better prepare all of us to be able to provide optimal oxygen therapy to COVID-19 patients. So Dr. Lipinski, thank you again for agreeing to do this. I know you're doing this out of the kindness of your heart, as are all individuals today. I'll turn it over to you and listen and hopefully learn a lot about it. Dr. Lipinski, thank you again.
Well, thank you very much, Dave, and thank you to the CCSO for giving me this opportunity and forcing me to review all the literature and really understand these issues. So what I'd like to talk about is oxygen and hypoxemia, talk about airborne transmission of this virus, modes of oxygen therapy, high flow nasal oxygen and non-invasive ventilation, and then end with the decision to intubate. So hypoxia, question of how low can you go? And for reasons that aren't 100% clear, there's this magical number of 88. Above 88, everything's good. Below 88, chaos. And where this number comes from is really home oxygen therapy. Studies in the 1980s identified that patients who persistently below 88% are going to have a shorter lifespan than those who are maintained above 88%. But it's not an acute parameter. And really what determines how much oxygen gets to organs is your oxygen delivery, which is dependent on the cardiac output, the hemoglobin, and the oxygen saturation. So cardiac output plays a major role here. If you've got a really good cardiac function, you can compensate for a low oxygen saturation by pumping more blood. You can double or triple your cardiac output and get oxygen to the organs. On the other hand, if you've got a really bad heart, old, frail, you may not tolerate a low saturation nearly as easily because you don't have the cardiac output. And this is highlighted by climbers who climb Everest without oxygen. The study from 2009, 4 climbers did arterial blood gases near the summit of Everest. And you can see these numbers here, saturation of 34%, 43% on my scale here, way down below the 88%. And not only were they surviving, but they were doing strenuous exercise. But they had a huge cardiac output. These are super fit people with a high hemoglobin running at around 200. Now, during COVID, in the early phase, there was this concept of happy hypoxemia that came up in the lay literature, Twitter, and published discussions, mainly by emergency doctors. And they came across patients who had markedly low oxygen, but seemed comfortable. And this seemed unusual, but when you look at it, it's not that unusual. Hypoxia is a stimulus for drive to breathe. It's not a good stimulus. There's a variable response. And with time, there's actually a loss of chemoreceptor sensitivity. And this can happen quite quickly. So the hypoxia doesn't give a strong drive to breathe. Hypercapnia is a stronger drive to breathe, but the VQ mismatch and shunt, which cause hypoxia in viral pneumonitis, does not cause hypercapnia. And any hyperventilation is going to drop the CO2 level, further decreasing the drive to breathe. Also, there's a suggestion that these patients might have better compliance than most patients with ARDS. The better compliance would imply less work of breathing and make them more comfortable. This group, Bickler, came up with this approach where you can see the mild to moderate to severe hypoxia, how the young, healthy patient compensates. The older patient or that with cardiovascular disease not compensating. But remember that cardiovascular decompensation can occur quite suddenly. So the patient who looks well can suddenly drop their blood pressure, become markedly hypoxemic, lose consciousness, asystole, and cardiac arrest. So important to follow them closely, but they don't necessarily need intubation right away. So the oxygen saturation less than 88% should not be a dichotomous parameter. Lower may be tolerated, and you need to individualize, assess the patient, look at other parameters, respiratory rate, accessory muscle use, diaphoresis, hemodynamic stability, and level of consciousness. Okay, so what about this concept of aerosol generating procedure, something that a lot of us hadn't heard about until COVID came along? So when we exhale a variety of droplets and aerosols. So what comes out of our mouth can be tiny aerosols in the range of 5 to 100 micrometers. And these remain suspended in the air for hours. And then they're larger droplets, 300 micrometers and larger, that tend to fall to the ground quite quickly. So there's a spectrum of droplets exhaled. These may be emitted by breathing, coughing, and by respiratory devices. and the spectrum is small to large, and larger droplets can actually evaporate in the absence of humidity and become smaller airborne droplets. The particle size that remains suspended, the so-called aerosols, varies in size from about 5 to 100 microns. Now remember that the concentration of particles decreases as distance from the source increases. And air movement and ventilation have a much bigger effect on the small aerosolized droplets than on large droplets, which are heavy and fall to the floor. So what are the mechanisms of producing aerosols by the respiratory system? And there seem to be three mechanisms. One is open closed cycling of glottic structures, shear forces due to high velocity gas flow against the mucosa, and open closed cycling of terminal bronchioles. So these effects all generate airborne particles. And contributing to that is the inflamed mucosa, which is going to be moist and more likely to produce particles, turbulent flow caused by the edema and the abnormal airways, airway collapse, and coughing all contribute. Now, inhalation of small particles is more likely to occur than inhalation of larger particles. And it has been shown that the SARS-CoV-2 virus can remain infectious in aerosols for up to 3 hours. It's also been shown that in the hospital scenario, infectious aerosols can be found almost 5 meters away from the patient's head. So they can travel a good distance. Now, we all have negative pressure rooms, which have high room air exchanges. And the room air exchange is important in diluting out the virus. So the usual is 12 air exchanges per hour, and this is the minimum suggested by Public Health Agency of Canada. And this is going to dilute out to 90% within 12 minutes and to 99% within 35 minutes. Preferred is a 15 air exchanges per hour. But if you're in a room with 12 air exchanges per hour, the virus in the room, even the aerosolized virus, is going to be significantly diluted out, protecting the healthcare workers in that room. Now, what are aerosol generating procedures? So the main reason for defining AGMP is these are situations where an N95 mask is needed. Now, this study looked at consensus on definitions of AGMPs. They found good consensus that intubation, extubation, bronchoscopy are AGMPs, but when you look at nebulized therapy, only 82% consensus, even high flow nasal oxygen, 86% consensus. So not everyone agrees on what is an AGMP and what is not. This is another study which labeled bronchoscopy, bag mask ventilation as extreme risk, non-invasive ventilation and high flow nasal cannula as only high to moderate risk, but then coughing and the dyspneic spontaneous respiration as high risk. So rating it higher than high flow nasal oxygen and non-invasive ventilation. So again, demonstrating the lack of consensus of what is risk and what is not. So let's look at it in a bit more detail. So the one area where there's been a fair amount of literature is the intubation. Everyone knows that intubation is a high risk. We now have standardized protocols where patients will have an RSI, they are sedated, they paralyzed, that there's no coughing to reduce risk to the intubating team. But this group from the United Kingdom actually measured aerosols in the operating room during routine general anesthesia for routine cases. So this graph shows on the y-axis the amount of particles that they measured. Now what I've got below is a scaled up version of the graph, 10 times scaled up, just to show, because you can hardly see the droplets on this scale here. But these are the droplets that are generated, and this is the point where the cuff is up and the airway is presumably protected. But then when you look at the extubation on the same scale, when the cuff comes down, the extubation seems to be a much higher risk. There are a lot more droplets occurring during extubation. This makes sense. You know, the patient's now awake, they're breathing, and they're going to cough. And then they got the patients to cough voluntarily, a volitional cough. And this is a whole different spectrum. So here's the intubation on the scale. Here's the single cough. So cough
I have somebody doing something right now. So let
Stephen, you have to unmute yourself, please.
Everyone got muted. So these are patients with normal lungs. and may have actually less aerosol generation than our COVID patients. Another approach would just be to use simple common sense. I think everyone on this call probably knows Randy Wax, who said the intubation isn't an AGMP until things go wrong. You haven't given an adequate RSI, there's a cough in your face, and hello, COVID. So what is the risk to healthcare workers of AGMP? So there are different factors. One is the production of aerosol particles by the intervention, which we've discussed, the distribution and concentration of aerosol particles, and there are also healthcare worker factors. So this group, published in Anesthesia this year, identified that the risk to the healthcare worker is proportional to the particle concentration we've spoken about, the healthcare worker's minute ventilation. So the more rapidly you're breathing, the more particle you're going to breathe in. The time that you're exposed in the room, which is a factor that we can control very easily, and the efficiency of the mask. So by reducing particle concentration, using an N95, and reducing the time, we can reduce risk to people. There is a standard approach to mitigation strategies, a hierarchy of controls, and elimination is the most effective, and that would be limiting staff in the room. Engineering controls, such as having high room air exchanges and exhalation filters on your circuit, would also help. Administrative controls, less effective, and this would be mandating RSI for intubation and avoiding bag mask ventilation. And really at the bottom of the hierarchy is the personal protective equipment, or the N95 mask. So in terms of personal protective equipment, this is out of my area of expertise. It's something that the infection control people deal with, but this would be the usual standard. So a gown, gloves, an N95 mask, and something to protect the face. So let's talk a bit about the different modes of oxygen administration. So I'd like to talk about flow rates first. So we saw initially that development of AGMP is dependent on the flow of gas, high flow gas against the mucosa. So this table is to look at flows. And before I look at the flows, let's talk about the Venturi mask. So the Venturi mask has a flow of oxygen coming from the oxygen source, but this system entrains room air to dilute that 100% oxygen down to say 40%, but this entrained air dramatically increases the flow. So although you're showing 10 liters on your wall oxygen, what's at the patient's face can be as high as 45 liters. So when we look here, nasal prongs can run at say 1 to 10 liters per minute. AGMP is by a lot of people considered greater than 6 liters per minute. Your Venturi mask, although the wall flow is showing 4 to 6, 10 to 12, 12 to 15 liters, what's getting to the patient's face is 30 to 50 liters. These are not generally considered AGMP. The non-rebreather mask with 10 to 15 liters flow rate, yes. And the high flow nasal oxygen at 20 to 60 liters, yes. So a few inconsistencies here in our definitions. Now, the non-rebreather mask is commonly used, and what we use in our institution is a non-rebreather with an exhalation filter. So this is the Tavish mask. Not everything gets filtered. There's obviously going to be leak around the mask during exhalation, but the majority is going to be filtered, reducing the amount of particle generated. Now, high flow nasal oxygen, as mentioned, has become something somewhat controversial. It's popular, it's easy to use, it's comfortable for the patients, but potentially high risk. So the benefits are the comfort. Patients like it, it's humidified, it's not something tight over their face. A theoretical benefit of flushing out nasopharynx dead space CO2. So by flushing out the CO2 in the nasopharynx, you could potentially reduce arterial carbon dioxide levels. This may reduce drive to breathe and reduce patient self-induced lung injury. So this P-SILI, patient self-induced lung injury, become very popular and controversial during COVID. Not entirely clear whether it exists, but it may be a reason for benefit of high flow nasal oxygen. There's also the story that it generates positive pressure. The positive pressure is really low. This study looked at normal volunteers, and at a flow rate of 50 liters per minute, flow rate of 50 liters per minute, there was a positive pressure less than 2 centimeters of water. With the mouth closed, it was 3.3, but really you're not getting a huge amount of positive pressure. In terms of benefits, this study in the New England Journal showed a mortality benefit. So high flow against a non-rebreather 10 liters versus non-invasive ventilation for 8 hours a day. And the striking finding was this 90-day mortality reduction of high flow nasal oxygen. And some of this attributed to the reduction in P. cili by flushing out the nasal dead space. A Canadian group did a systematic review of high flow nasal oxygen and COVID-19. There are actually no good studies on COVID-19 and high flow oxygenation, but the studies they did find showed a low certainty that it may reduce invasive ventilation and no difference in mortality or length of stay. So not a lot of good positive data. An international group developed clinical practice guidelines, first authored by Bram Rockberg from Hamilton. And this gave a strong recommendation for use of high flow nasal oxygen in hypoxemic respiratory failure. Now, again, this is not specifically COVID related, and conditional recommendation following extubation and for post-operative in high risk, but not in the peri-intubation period. Now, there's been significant variation in the use of high flow nasal oxygen, used extensively in Wuhan in February and March, not used at all in Seattle when they had their big outbreak. And one of the concerns is the dispersion of the exhaled air. And the dispersion can be reduced with a good sized cannula, well fitting in the nose. This study looked at the dispersion distance. So the distance from the face at 60 liters was 17 centimeters, down to 6 centimeters with 10 liters, very similar with a simple mask, and actually much higher numbers of distance of dispersion with the non-rebreather and the Venturi mask. It has also been shown that by placing a surgical mask over the face of a patient on high flow or a regular oxygen mask not connected to anything, you can dramatically reduce the dispersion. So this shows dispersion without the mask and dispersion with the mask. They've also shown that there's no change in PaCO2, so you're not going to be rebreathing by putting a surgical mask over high flow nasal oxygen. But can intubation be inappropriately delayed? So is there a risk of progressive fatigue despite good oxygenation by using high flow nasal oxygen? So a French group have developed this ROX index, which is the oxygen saturation to FiO2 ratio divided by the respiratory rate to predict respiratory failure. And if this ratio is greater than 4.88, there's very little risk of respiratory failure. So the ratio will go down as the respiratory rate goes up or as the saturation goes down. And they've shown a cutoff for risk of failure 2 hours, 6 hours, and 12 hours. It's really not clear what the value of the ROX value is. We're starting to track it in our ICU, but we're not sure what to do with this information. I think if you have a number above 5, everything is good. Below that, there may be a concern, but definitely need ongoing usual clinical judgment. So non-invasive ventilation, role in COVID. So the major benefit of non-invasive is in patients with COPD and cardiogenic pulmonary edema. And outside those two conditions, the data is fairly thin. It may be used to avoid intubation in hypoxemic patients. The data in COVID is quite minimal. A case series of 61 patients in the emergency room showed a success rate of 72%. It is considered an AGMP because of significant dispersion of aerosol into the room. Now, most systems are a single tube with a vented circuit. So the circuit has built-in holes into either the mask or the circuit to allow air to escape. The flow from the ventilator is going to allow CO2 excretion, but causes dispersion into the room. But you can do a closed system non-invasive. So this is a mask without any holes in it. It's a closed system, and there's a viral filter on the exhalation. So with the closed system, you can actually achieve a very good effect with very little viral dispersion into the room. Another approach is to use the helmet, which has become quite popular. So the helmet has an inhalation port and an exhalation port, and this can be viral filtered. And some systems that have a good neck seal can reduce dispersion. So this is a picture of the neck seal. It's actually me playing around with a helmet and playing on the ventilator, but it really showed the neck seal very well. And I thought I'd use that picture. This is a study looking at a helmet without a neck seal showing a big dispersion of air into the room, and one with a neck seal and showing nothing escaping into the room. So it can be done quite effectively. And in Italy, they had large rooms of patients on non-invasive via helmet, supporting them during the initial outbreak in March and April. Now, when you look at the maximal exhale distance with various non-invasive masks, it's up to 0.5 meter. And then using this helmet StarMed mask with the good neck seal, negligible exhaled air. Now, various organizations have given their recommendation on which is preferable, high flow nasal oxygen versus helmet CPAP or other CPAP. And as you can see, it's all over the place. And I think it really depends on what your definition is. Is this high flow with a surgical mask on? Is it a helmet with a good neck seal, or vice versa? But there's really no consensus on what is the optimal approach. Another study looking at dispersion distance, oxygen via nasal cannula, dispersing to 1 meter, venti mask 1/3 of a meter, and then this helmet with a good neck air cushion, negligible dispersion. So what is our official Public Health Ontario's opinion? These are the conditions considered aerosol generating. So intubation, tracheostomy, bronchoscopy, non-invasive, high flow, induction of sputum, and this all depends on how you're doing the procedure. Interesting, this is the list of procedures not considered AGMP. So a ventilator circuit disconnect, coughing, chest physiotherapy, and oxygen delivered less than 6 liters per minute by nasal prongs. So I think it's important to have an individual risk assessment, identify the risks, and decide in your particular patient what is risky and what isn't. A few words about awake proning. So awake proning is something that is technically feasible. It can be done with high flow and with non-invasive. It may improve oxygenation acutely, no real data on long-term benefit. This rapid systematic review showed small uncontrolled studies or retrospective cohort studies, no standardized duration of proning, and not tolerated by some patients. I thought I'd show you some of this limited data. So an ED study of 50 patients, the saturation increased after 5 minutes, 13 were intubated within 24 hours. Hard to know what to make of that. 24 patients, 63 tolerated 3 hours. Now remember, in the Proceva study in ventilated patients, you needed 16 hours to get a benefit. So whether this 3 hours is beneficial at all, don't know. A quarter had a 20% increase in PO2, a quarter got intubated. There are other studies underway at the moment. The COVID prone is the one we're involved in. So finally, the decision to intubate. Early intubation was recommended following the experience in China due to the severe hypoxemia and to avoid transmission. So we didn't want emergent, sudden, uncontrolled intubation in the middle of the night, rather intubate in the light of day when everything can be controlled with experts at the bedside. Also, high flow and non-invasive were discouraged, so moving on to intubation was the way to go. And RSI carries an increased risk in the very hypoxemic patient. But Martin Tobin, way back in May, June, said the surest way to increase mortality is liberal use of intubation and mechanical ventilation. So if we're not recommending early intubation, what do we recommend? And it's pretty much business as usual. Physician judgment, the patient with clinical distress, altered level of consciousness, hypercapnia, hypoxemia associated with some end organ problem, or a trend towards these, but not just because the patient has a low saturation or is breathing rapidly. This has all been put together in a review in CHEST, not rocket science, but step 1, the regular oxygen, step 2, going on to high flow or proning or non-invasive, and then step 3, mechanical ventilation. So business as usual. That's all from me. And now I'll hand it back to Dave, who presumably has some questions.
Well, Stephen, certainly thank you for that. Certainly, I find the issue of AGMP one of those ongoing, challenging, poorly understood issues. So I appreciated your perspective on it. As we get ready to do some of the questions, I just want to remind everyone the webinars are recorded and will be available for download. The questions are being collated, but some that aren't answered today will be brought forth in the December webinar when Dr. Lipinski and Dr. Fang will be coming back to talk with us. So if you come up with questions later on, please send them in to info@ccso.ca. And perhaps I'll start off with the first question before we get Neill to ask some. I was wondering, what have you found that you've changed the most in your practice of managing COVID-19 patients in terms of respiratory care, if you compared the spring wave to the present situation? What would you say has been your biggest change?
Well, I think we did have a blanket ban on high flow and non-invasive in the beginning, and now we are allowing it. We're taking precautions. We preferably use a negative pressure room with high air exchange, but there have been times when we haven't had that available. But they both do provide some benefit, and we're also not intubating early. I mean, we did have early on, we had some patients.
Questions are being collated.
Oh, that's someone on YouTube and a delay. We did have some that we intubated very early on, and she actually did very well and came off the ventilator in 3 or 4 days. In retrospect, probably didn't need intubation. So we are watching them closely, but not rushing to intubation early on.
So just to clarify that, you will use the high flow in some of those devices in single patient rooms, even if they're not negative?
Yes, we do it in conjunction with IPAC, and they generally agree with us. Sometimes they don't.
Yeah, no, we're the same. Certainly, we do that, and then have our staff wear appropriate PPE. Dr. Adhikari, welcome. We'll call you Q&A for a while here. I was wondering what questions have come up that you'd like to share. I'll pass it over to you right now.
Thanks very much, and thanks very much, Dr. Lipinski, for a very comprehensive but efficient review of this complex topic. I'm impressed with the amount of literature, both that's been published and that you've managed to review for this. One question that, and if you, audience, if you have questions, please feel free to fire them off to me. I'm called Q&A here, I think, or to Dr. Thériault, who's Q&A. And we'll pose them. One question is around criteria for proning intubated patients, and I'm wondering maybe if we should defer that until Dr. Fan speaks in a couple of weeks. But if you want to, Stephen, if you want to, give your thoughts about that, then
I think that's Eddie's thing. But we would use the standard sort of ProSiva criteria for proning our patients. You know, it's ARDS. I know there's been a lot of controversy with Gattinoni and Martin Tobin getting into a fight in the literature, but we would treat it as routine ARDS and prone according to the ProSiva criteria.
Great. Another question here from Nav Mehta is, and I think this is a nice question about if you could comment on the role of bag valve mask ventilation in patients that are either COVID positive, COVID pending. You know, you do sometimes get in the situation where despite an RSI and everything being optimal, like it's not possible to intubate the patient immediately, and you're sort of forced into a situation of BVM. And what are your thoughts about that as a procedure and about making it as safe as possible?
Yeah, so again, it's something you'd preferably avoid. And the big problem is if there's high flow, so big bags, big breaths with a poorly fitting mask. So if you are going to do it, you'd want a 2-person approach with one person holding the mask on really tightly and the other person doing relatively small breaths. You don't want big breaths where there's high pressure generated that's going to firstly generate aerosols and secondly spray them into the room. So a tight fitted mask and someone doing gentle bagging should definitely reduce the risk.
Great, thank you. And maybe I'll ask one more, which is you showed some data on dispersion with various devices, and I guess my question is, sometimes we're in a situation where we're maybe using high flow nasal cannula or non-invasive ventilation with maybe without being able to set up the closed circuit for exhalation. Do you think the risks there are sort of manageable? If, for example, with high flow nasal cannula, there's a medical surgical mask on the patient, and with non-invasive ventilation, if you're able to at least have a closed room as opposed to an open area.
Yeah, so again, it's all a matter of weighing up the risks and doing an individualized assessment. If you can cover the high flow nasal oxygen, you're significantly reducing the dispersion into the room. If you can't cover it, or if you have a leaking non-invasive, if you're in a negative pressure room with high air turnover, the risk is much lower than if you're doing this in an individual room without a high turnover, because within a matter of minutes, you're going to have a lot of aerosol in the room. Whereas with the high turnover, you're keeping that relatively diluted. So it's considering all of those factors in your risk assessment.
Great, thank you. And maybe some questions now that have been directed to Josée.
Sounds good. So Dr. Thériault, have you been able to get some questions as well? And we'll turn it over to you now.
Yes, thank you very much. Thank you, Dr. Lipinski. Thank you, Dr. Neilipovitz. Yes, I've had a few questions through the chat of the Zoom. So far, none through the YouTube channel. So I think we're all curious about, and we've all had multiple meetings about the inconsistency of some of the guidance between the venti masks and the high flow nasal cannula versus non-rebreather. So the question is, in your opinion, how would you assess the risk of the venti mask in consideration with their flow rates compared to the non-rebreathers and the high flow nasal cannula? The $1 million question.
Yeah, a very good question. For some reason, the Venturi masks haven't been designated as AGMP, but when you look at the flow, it really is a high flow. And the lower the FI2, the higher the flow. So if you're a 24% mask, you're entraining a lot more air, so you've got a much higher flow at the face, maybe 50 liters. Whereas if you're on a 40 or 50% Venturi mask, there's much less entrained air because you're not diluting the 100%. So the flow might only be 25 or 30 liters. But I would still be concerned, and I think those patients should still be treated very carefully, that potentially there is a lot of exhaled air dispersing into the room.
Thank you very much. There is another question concerning the use of high flow nasal cannula and or CPAP to maintain oxygenation pre-intubation. So preferences, risks, your opinion.
Yeah, so if you are sedating and paralyzing the patient and they're markedly hypoxemic, the better you can oxygenate them prior to making them apneic, the more likely they're going to survive your intubation. So whatever works, if they have been on non-invasive or if they have been on high flow, then I would continue with that. If you're intubating them from a Venturi mask, maybe they don't need intubation if they're desaturating a little bit on a Venturi mask. So most of these patients would be on some higher level of oxygenation prior to being intubated, and maximizing your oxygenation prior to making them apneic would be ideal.
Thank you. A few more questions. Dave, do we still have time?
Yep, I think we're going to aim to go to about 12:45. So why don't you ask one or two more, and then we'll wrap it up here.
There was a question about people who come in and test positive, and the recommendation of not testing and just wait. And we're referring, I presume, here to critical care patients, just to wait basically that 3-week period, regardless of the results of the test. So may we have your comments on this?
I'm not sure I understand. So you mean considering them all positive?
Yes.
I think anyone who comes into the ICU initially need to consider positive. And we know the tests are not perfect. I mean, we would test everyone. Luckily at Mount Sinai, we get a very rapid turnaround, but I know in some centers it may take 12, 24 hours or even longer. You've got to take precautions and consider everyone potentially at risk. And there are the occasional false negative. If it's a badly done nasal swab, you may get a negative, and you don't want to expose people. So rather err on the side of taking precautions than not taking precautions.
So if I may extend a little bit on this, if patients that do come into the ICU that are positive, COVID positive, get intubated, have a repeat swab done that is negative, do you consider them negative, or do you consider it a potential for false negative and continue to provide the same COVID and same PPE?
The whole area of when are the patients negative is another whole area that is not in my expertise. I do know that for non-critically ill patients, it's now considered, it was 14 days and it was 11 days, and I think now 8 days, test positive or negative, they're considered to be clear. Remember, the PCR test can remain positive even when you don't have infectious organisms. I just don't think there's the data in the critically ill patient to know when they are clear. We don't routinely do follow-up testing because we don't know how to interpret it. So if we get a negative PCR or a positive PCR at 3 weeks, we don't know if that's a problem. And I think pretty much we're continuing to consider them infectious throughout the ICU stay.
Thank you very much. There's a few more questions coming up, but let me see.
Perhaps we'll take one more, Josée or Neill, and certainly the challenge of not only when they've been negative, I'm sure you'll appreciate, Stephen, is that we've had negative patients, and then only to find that weeks later they suddenly become positive while in hospital. The challenges of allowing family members in, the nosocomial spread and various changes like that can create exposures that all of us have probably had to deal with in some fashion. So it's probably challenging for you to say when is someone ever truly negative. I can't imagine I would be able to say that with 100% certainty.
Yeah. I think we've had a case in North Bay that the patient had COVID during the first wave, presented, I think was over 2 months after the first wave, and tested positive again. So I'm not too sure what that means, but certainly creates even more ambiguity. There was a question follow-up to a previous question, and Dr. Lipinski, they were asking at your center, what do you mostly use, Ventimask for oxygenation or high flow nasal cannula, or a combination of both depending on the patient?
What we're predominantly using is the Tavish non-rebreather mask. So the non-rebreather mask with the exhalation filters. And that's pretty much our standard for anyone with COVID or suspect of COVID. And some of those would go on to get high flow nasal oxygen, but the vast majority we're using the Tavish mask.
Okay. Thank you very much. I will be saving the chat box to review further.
That's great. Thank you, Josée, and thank you, Neill, for asking the questions, and again, to encourage people to send the questions in to the email address info@ccso.ca. Stephen, certainly appreciate the time and effort that goes in. I know reading the multiple articles, you've probably learned twice as much as all of us, but certainly we certainly are appreciative of what you've taught us today. And we look forward to you coming back in December as being part of the panel when we have additional questions. I just want to thank the team from CCSO. This was a lot to put together in less than 2 to 3 weeks. And so they've certainly learned a lot of things. And we do welcome suggestions for future topics and future ideas. So again, Dr. Lipinski, thank you for taking the time and effort, and thank you to everyone for joining us today. We look forward to seeing you again in 2 weeks' time. All the best to everyone. Take care.
Thank you.
Thank you.